Thank you very much for that kind introduction, and allow me to also thank the organizers for inviting us. It's been a fantastic 2 days, meeting old friends again and making new friends. I'm going to try and speed up my talk because I think I have 20 minutes left. So from football back to earth and to track and field. Now I work at Aspetar in a clinical role, but also in medical education. I have an academic association with Weill Cornell University, but, and I think this is because I'm last, I'm also a student. So I'm a PhD student at the moment, studying evidence-based healthcare at the University of Oxford. So this is Philip Sidow. He's an Olympic triple jumper. I want you to look at his left hip. He's uninjured. But look at what's happening in his left hip. So if we see that, and if I'm the medical doctor looking on television and this is my patient, I get a huge fright. The biomechanist can tell me what's going on, and this slide I haven't stolen. Phil Graham-Smith gave it to me, and Phil Graham-Smith tells me that the vertical force going through Philip Sidow's hip is up to 20 times body weight with every jump he takes. But he won a silver medal at the Beijing Olympic Games. He won a gold medal in 2009 in Berlin at the World Championships, and he won a silver medal in 2011 in Daegu. He's never had a hip problem. But hypothetically, he might have had, let's call it, primary CAM morphology without symptoms. A bump at the femoral head-neck junction, and maybe from time to time he might have had subtle symptoms because of primary CAM morphology. Just to let you know, I'm not going to talk about secondary CAM morphology. Primary CAM morphology is my area. So Phillips, his coach, and you might be interested in asking a few questions. One, what is CAM morphology? So a definition question. Two, why did I get this? So an etiology, but also a prognostic question, and I'll go into that a little bit. He might ask you, so what? Is it going to affect my performance? Clearly it didn't. And what might happen? Again, a prognosis question. So to answer these questions, we should base our clinical reasoning on the scientific literature. And the 5A model for using the medical literature to provide optimal patient care is such a way. So first of all, ask the so-called PICO question: patient, intervention or exposure, comparison and outcome. Acquire, get the best relevant evidence. Appraise that evidence, look at the risk of bias of the evidence, and look at the results of the evidence. Then apply that evidence. Is it possible to generalize the results to the individual patient? And what is the significance of the results? How do I balance the benefits, the risks, and the prognosis and the burdens to my patient? And finally, act on the results using shared decision making. Now, it is slightly more complicated for primary CAM morphology. And we've heard over the last 2 days that we do not fully understand the etiology, the risk factors, the prognosis or harm, screening for CAM morphology, and the best treatment options. So there are a number of cracks and crevices compromising our ability to apply the scientific literature to the current clinical practice around primary CAM morphology. So I'm going to focus on 3 things. I'm going to discuss briefly what the difference is between etiology and prognosis. I'm going to look at research quality and research availability and how that might have an impact on our clinical practice. And finally, spend some time discussing communication, risk, and uncertainty. So this might be the diagnostic PICO question. In a 23-year-old male, does triple jump cause primary CAM morphology? So I think you'll agree, an etiology question. But as I've said, it might also be a prognosis question if we ask what are the prognostic risk factors for a 23-year-old to get cam morphology. And I find this an easy way to communicate hazard and risk to my children. If you swim in the ocean, a shark is a hazard. So a hazard is something that has the potential to harm you. Risk is the likelihood of a hazard causing harm. The same with triple jump. Triple jump is a potential hazard, and that potential hazard has the possibility, or what's the likelihood of that hazard causing primary cam morphology or FAI syndrome or osteoarthritis. An alternative question might be, in a 23-year-old male triple jumper, does primary cam morphology cause pain or osteoarthritis? A prognosis question. And it might look like this when we discuss this with our patient or with our children. Now, what are the differences between cohort studies on etiology and prognosis, and why are they different? First of all, in etiology, the objective is to determine the causes of a particular health outcome. Primary interest is in the effects. While in prognosis studies, the objective is to predict the health outcome, and the primary interest is in the outcomes. Only exposures that can be manipulated are of interest. Only they can have definable causal effect. And we heard that yesterday from Mick. In prognosis, any exposure can be a predictor. The analysis of etiology is theory-driven, while the analysis of prognosis can be data-driven. The problem is overfitting of our model. In etiology, models must include all non-ignorable determinants of outcome, including confounders, while in prognosis studies, confounding is less important. Simple models with a few predictors are preferred, although we know that your model is less robust if you don't include some of the confounders. Less predictors are more helpful in clinical practice. Now, what's the situation in primary cam morphology in terms of the availability and the quality of research? And we asked this question in a systematic review that I did with colleagues. What are the risk factors for development of primary cam morphology? And a secondary question, how was cam morphology defined? So we registered our systematic review on Prospero, and we searched a huge number of electronic databases with no language restriction, and did the title abstract screen of 3,656 papers, full text screen of 262 papers, and included 107 papers in our final systematic review. Now, all 107 papers are observational, either cohort, cross-sectional, or case control. We excluded case series and we excluded qualitative research. Now, we all know that a quality assessment of included studies is perhaps one of the most important things of a systematic review, but often neglected when we discuss a systematic review at a conference. So I'm going to spend a few minutes on the quality assessment of our systematic review. We combined two tools, the so-called risk of bias assessment tool for non-randomized studies and quality in prognosis studies, ROBANS and QUIPS tools. And this is what you'd like to see. Everything green in participant selection, confounding, risk factor exposure measurement, outcome measurement, attrition, or selective outcome reporting domains. So low risk of bias in all domains. It hasn't been published, so please don't tweet, but this is the result of our systematic review's quality assessment in the 6 different domains. The first domain is participant selection, or so-called selection bias domain. And one of the most important reasons why this domain had a low score was the populations of interest was not adequately described. The sampling was biased, and in a number of papers, the period, the place of recruitment, and the inclusion and exclusion criteria were not adequately described. There was inadequate participation, and often no baseline criteria of the participants included. The second domain is confounding, are all the important confounders measured? So one of the important things here is that all the important confounders were not clearly defined, measured, accounted for in either the design or in the analysis phase. And were the measurement of the confounders valid and reliable? The third domain is performance bias or inadequate measure of the exposure or risk factor. In a number of studies, there were no clear definition of the method of risk factor measurement. They were resulting in misclassification bias. Other possibilities here that we should consider is the use of continuous variables. Were there appropriate cutoff points used in the exposure or risk factors? And what was the method and setting of risk factor measurement the same in all participants? And for a number of studies, it wasn't. I'm going to spend some time in this domain. So this is the detection bias domain or outcome assessment, how the outcomes were assessed. For a number of papers, there were no clear outcome definition. The methods used to measure the outcomes were not adequately valid and reliable. So this might lead to misclassification bias. Now, we've heard a lot about alpha angle and how the alpha angle is measured, and this is perhaps gold standard. So radial images around the axis of the femoral neck every 30 degrees, and this was published by Anthony Palmer in his 2017 cross-sectional studies. But we've also heard that alpha angle can be measured on the AP pelvis or lateral radiographs. And this is how Anthony described his imaging in his paper. And the final paragraph there is, radial images were acquired around the axis of the femoral neck at 30-degree intervals. And there's an online supplement where you can clearly read what he's done. So a very good description of the imaging done. To account for variation in the location of camoufology, the primary outcome measure was maximum cartilage alpha angle from the 11 o'clock to the 3 o'clock region, and blinded, so the measurements were performed by an academic orthopedic clinician, very important, blinded to the participant information. So clear information about how the outcome measure was dealt with. Now this is a cartoon that I think will describe to anybody who doesn't know what an alpha angle is, clearly what it is that we are measuring. Normal alpha angle and an abnormal alpha angle, or an increased alpha angle on your right-hand side. And it's often described in the literature as a so-called continuous variable, or a mean alpha angle in a population. But there's also huge heterogeneity in terms of cut-off values used for alpha angle. And then this is how they define camoufology. Either no camoufology below a certain cutoff, or above an arbitrary cutoff camoufology. And in the 33 papers that we included in the sport, dance, and physical activity section of the systematic review, these are the cut-off values that were used in the papers, from 50 degrees, 50.5, 55, 60, 78, and 83, and at least one paper didn't describe what the cut-off value was that was used. Now, there's one thing that I perhaps want to emphasize is the importance of not dichotomizing a continuous variable when you want to do prognostic research. There's perhaps no reason, and I know this is maybe challenging, there's perhaps no reason why we should dichotomize a continuous variable like the alpha angle when we do prognostic modeling. Why not? So we reduce the statistical power. It's as when we dichotomize a variable along the median, it's as you might just as well discard 1/3 of your data. And it underestimates the extent of variation in outcome between groups. So individuals close to but on opposite sides of the cutoff point are categorized as being very different rather than being very similar. So these are the two important problems with dichotomizing a continuous variable. In the fifth domain, we looked at attrition bias or incomplete data. And in the final domain, reporting bias, so selective outcome reporting, and we also judged the statistical analysis of the papers. So why are most published research findings false? And this is a very famous 2005 paper by John Ioannidis, one of the most highly cited papers in biomedicine, I think more than 3,500 citations. So research findings in a scientific field are less likely to be true when the studies are small, when the effect sizes are small, when the greater the number and the lesser the selection of tested relationships, the greater the flexibility in designs, definitions, outcomes, and analytical methods, the greater the financial and other interests and prejudice, and finally, the hotter a scientific field, or so-called hot stuff bias. Now, I think all of these apply to some other extent to the research field of primary care morphology etiology. We should ask ourselves 5 questions related to avoiding research waste. The first question is, are research decisions based on questions that's relevant to the users of the research? Second, is there an appropriate design, methods, and analysis of our research? Is there efficient research regulation and management? Is the research information fully accessible? And finally, is it unbiased and in a usable fashion reported? So perhaps all of us engaged in the enterprise that we call science need to pause and reflect on the present state of what we do. And the good news is that we've done that, and a number of us will, in the next year or 2, 3, collaborate on an ambitious project to do a prospective individual patient data meta-analysis on why care morphology developed. So a lack of good quality evidence compromises our ability to use evidence in decision making, and it creates uncertainty. So in the next final session of my talk, I'm going to discuss a little bit how we communicate risk and uncertainty. And I won't use this role model. You will know that there's no country like Namibia. For me, that's from South Africa. I did my housemanship in Namibia, so this is very close to my heart. So what is risk communication? Risk communication is an open, two-way exchange of information and opinion about risk, leading to a better understanding and better decisions about clinical management. It is not easy to communicate risk and uncertainty, and we working in clinical practice, us in clinical practice will know that. And most patients assess risk primarily based on emotion and facts. Now, if how patients feel influence their understanding of the facts, their ability to make objective decisions about clinical management will be impaired. So communicating risk and uncertainty can only be done in true partnership with the patient and important others. And we've heard that on a number of occasions today and also yesterday. For example, the coach. Sharing difficult decisions about preferences, perceptions, coping with uncertainty and risk. And for this to work, mutual trust is paramount. We've heard just now that confidence is what the doctor needs. I want to argue that most of all we need to be caring and competent. And when we're caring and competent, then humble confidence will facilitate our relationship of trust with our patients. And this is certainly my experience working with some of the best track and field athletes in the world. So trust underpinned by displaying both competence and a caring approach is what we need. So if we communicate risk, I want to argue that we cannot do that without doing it in a shared decision-making way. I've published this editorial with Claire Ardeur and others. The athlete is, of course, an important person to take into account in shared decision-making. Healthcare professionals, and I want to emphasize the healthcare professional team. And finally, the coach. The athlete will bring subjective contribution to the consultation, his preferences, his values. The coach, contextual contribution, the athlete's current ability to perform. And then the healthcare professional team, an objective contribution about the health status, advice on management and outcome. And I wish I had this model long ago when I practiced with the athletes in the UK, and I'll show you just now why I'm saying this. So this is a cartoon from Elwyn's paper in the British Medical Journal last year, providing us with a framework of shared decision making. Team talk, option talk, and decision talk. And we call that collaborative deliberation with the patient. As a team, we need to explain the need to consider alternatives. Are we going for physiotherapy or are we going for surgery? And why is there uncertainty in this specific situation? So we describe the alternatives in more detail and then help the patients to explore and to form and integrate their personal preferences. So we talk about original preferences and then the personal preferences after the discussion. And this is in more detail from the paper. And I'm going to skip this. Now, this is Jessica Ennis. She was a gold medal heptathlete at the London Olympic Games in 2012. But disaster struck in 2008, just before she, 19-year-old, was supposed to be one of the British star athletes at the Beijing Olympics. She published a book after her London success, and in this book, she reflected on the terrible time before she had to withdraw from the Beijing Olympics. And I was the doctor who had to give her the bad news. And there's a video of how I've done this. And I've had the time to reflect on my words and how I've done this. And this is the video. Listen to her words. Specifically the emotion. There's the physiotherapist in the room.
Do you want me to leave? Yeah. Okay.
Okay. The scans have revealed Jess's worst nightmare.
There and then I was told that I've got 3 stress fractures and that you won't be going to the games. I couldn't believe it. I just felt like really numb. So I didn't know what to say, I just cried. It's horrible. At any other time it would have been disappointing and gutting, but because it's the Olympics, so close to the Olympics, it just intensifies everything and makes it 10 times worse.
So, and in her book she said, and I agree with her, that I said, his look told me everything. And Doc, being a clinician, was not one to sugarcoat the truth. I might add, a Dutch clinician. You're not going to the Olympics, he said, and it's a serious injury, your career might be over. So I think all these things true from the evidence on a navicular stress fracture. But maybe upon reflection, this could have been dealt with in a more nuanced way in the shared decision-making consultation. So communicating evidence and risk and uncertainty is at best emotional, it's messy, it's contextual, it's individual, and it's difficult. So much more difficult if we do not have quality evidence to bring to that discussion. So I've discussed partnership in shared decision making. I've discussed the importance of trust, care, and competence. I want to give a few strategies for discussing risk, because this is a whole research field that we know very little about and we receive no training in. So we have to be careful about the words we use. We have to supplement the verbal explanation with other media like pictures and diagrams. Now this is a word cloud from the 33 papers we included in our systematic review, and the different terminologies used to describe camophology in these 33 papers. And what's standing out is deformity, lesion, abnormal, etc., etc., giving an indication of how we communicate about camophology to each other and how we communicate about camoufology to our athletes. And this is, in one paper, 10 different ways to refer to the same entity: primary camoufology, femoral cam, cam impingement, cam hips, etc., etc. So different terminology given for the same condition influence the management preferences and the psychological outcomes in a consistent pattern in patients. We should use plain language, we should be consistent, and we should make it visual. A few pointers to communicating numbers. We should use numbers in the form of natural frequencies, not percentages. Example, 3 in every 10 and not 30%. 20% of US graduates do not understand the difference between 1%, 5%, and 10%. 20% of US graduates do not understand the difference between 1%, 5%, and 10%. We should use small denominators where possible, example 4 out of 10 and not 40 out of 100, and we should discuss and use absolute risks rather than relative risks. So, the risk is 1 in a million with treatment A and 2 in a million with treatment B. Do not say the risk is twice as big with treatment B. And then finally, be very aware of how we frame our messages, either positive or negative. So clinicians influence patients not only by verbal communication, but also non-verbal communication. And this is a fantastic qualitative study on plastic surgeons. The patient's body can be used by plastic surgeons as to promote the desirability of surgery. And then I quote, by touching excess tissue, pinching it, moving it, or applying tools and artifacts on and around the body, plastic surgeons literally bring to life the patient's bodily flaws. Constructing the patient's body as a territory of surgical need. Now, I think we can stand back and reflect, not only the surgeons, but is the PRP in my left hand, the PRP injection, or the stem cell in my right hand, or the modality in the back room without evidence? Are we constructing a way to use those things in our verbal language and in the non-verbal language with patients? So what clinicians choose to say has consequences for what patients go on to say and do. So I want to end again with these 4 questions that Phillips and his team might have asked about camoufology definition, etiology, performance, and what might happen. And this might be how I would have discussed it with him in practice. Camoufology is a specific shape of your hip. It's a bump close to the ball of the hip. I wouldn't have used the word lesion. I wouldn't have used the word deformity necessarily. This is the word that I might have used to discuss with Phillips what he has in his hips, or potentially has in his hip. I will make sure that he doesn't confuse association or connection with and causation. If we tell a patient 40 or 50 or 60% of footballers might have camoufology, they immediately think football cause camoufology. And I quickly added this slide after Kay's lecture. So this is a pictogram and a nice way to discuss with patients, for instance, osteoarthritis. So in Rintje's study, 1,411 hips, 2 out of 100 of the patients in general developed end-stage osteoarthritis. Of those in 5 years, those with an alpha angle of more than 60 degrees, 11 out of 100, and those with an alpha angle more than 83 degrees, 25 out of 100 in a 5-year period. And this makes it very clear to us and to the patient what we mean. And I will emphasize the importance of shared decision making. I'll emphasize the fact that the physiotherapist in my team can do a huge amount to help you to cope with what you have. You don't need to demonize or medicalize this morphology. So I'm ending. The real world of primary cam morphology is uncertain and complex, and at the moment perhaps a little bit messy, like Brexit. It's good to use scientific evidence in decision making. The 5A framework help us to do that by asking, acquiring, appraising, applying, and acting on. It is difficult to use the scientific literature if little evidence is available, or if the quality of the evidence available is low. Then we have to be comfortable and competent in communicating uncertainty. We should use shared decision making when communicating risk and uncertainty. And the communication tools to use is, first of all, trust, competence and care, simple language, simple and absolute numbers, make it visual, and be careful about biased framing. I want to thank all my current collaborators, Claire Ardeur, Mike Clark, Andreas, Andrea. This is a monster systematic review, and I think we will soon be finishing. Thank you very much.